Okay, thank you so much, Dr. Awad. I'll try in the next 20 minutes or so to talk about some of the important literature in 2023. I picked some of the published paper in General ID that I think that will change the practice. If you think other papers should be included, please share with us after the talk. So the first paper I wanted to talk about is the ATTACK trial. It's regarding testing a new product, the sulbactam, durlobactam, versus colistin for treatment of patients with Acinetobacter infection. This was a multi-center trial that included patients 18 years or 18 years or older. They included patients with Acinetobacter baumannii carbapenem resistant. The patients included in the study were hospital-acquired pneumonia, ventilator-associated pneumonia, patient with bloodstream infection. They randomized patient 1-to-1. All patients in the background received imipenem. Most of these patients had carbapenem-resistant Acinetobacter, but also they have co-pathogens, and this is the reason why they received imipenem in the background. The primary endpoint was the 28-day all-cause mortality. Just a quick note about this novel product. It's the sulbactam, as you know, has direct antibacterial activity against Acinetobacter. It's inhibits penicillin binding protein. The durlobactam is a novel beta-lactamase inhibitor. It has activity against class A, C, and D, including the OXA type carbapenemases, which is commonly seen with the Acinetobacter. So this is the main result. If you look at the forest plot and on the top right side is the favoring sulbactam, durlobactam. Left side favoring the colistin. You see the primary endpoint, which is 28-day all-cause mortality because of the carbapenem resistance Acinetobacter. And clearly you can see that the confidence interval fell within the non-inferiority margin, which was 20%. But actually numerically maybe favoring the sulbactam, durlobactam compared to the colistin. If you look at the Kaplan-Meier curve and the lower of the slides, you see the red color represent colistin group and the blue color represent the sulbactam, durlobactam group. And this is for the all-cause mortality. Clearly you can see numerically that patients who received colistin are at much more risk of death compared to the sulbactam, durlobactam group. And these are other outcomes from the study that I think important. So if you look at the secondary outcome, in particular, the microbiological outcome, you see the group who received the sulbactam, durlobactam group much higher microbiological eradication of carbapenem resistance Acinetobacter compared to colistin. Another important point, which was a primary endpoint, actually, primary safety endpoint, was the renal dysfunction and the outcome of renal dysfunction between the two products. Patients who received the sulbactam, durlobactam group had 13% risk of renal dysfunction versus 38% of the group who received colistin. So much higher difference, significant difference between the two groups in terms of renal dysfunction. So in conclusion, I think the strength of the study, this randomized controlled design, it's a relatively large number of patients, but what was really remarkable to me, the severity of illness of these patients. These are patients very comorbid. If you look at the Apache score in the overall population included, and this population was very high. And this is the type of patients we see with the carbapenem-resistant Acinetobacter, very comorbid illness, high SOFA score, high Apache score. So this was actually good and commendable to the authors to include such a patient population in a randomized controlled fashion. Limitation, I think maybe one minor limitation is the absence of long-term follow-up beyond the 28 days. But the other limitation, well, I think it's an important limitation, is the open label design of the study. So in conclusion, from this trial, that patient treated with the sulbactam, durlobactam group had higher clinical cure rates and microbiologically significantly higher number of microbiological eradication compared to those patients in the colistin group. Also, as a primary safety endpoint, those patients also had much lower dysfunction, renal dysfunction compared to the colistin group. Just a quick note that this product is now FDA approved. It was approved in 2023 for management of Acinetobacter carbapenem resistance. The second study, again, published in 2023, probably you heard about the RSV vaccine. So this is maybe just a summary of the finding from this study. As you know, the RSV development vaccine has been challenging for the last 50 years. And finally, it came to light. Several products now we have, after identifying the target that elicit the best immunogenicity for or neutralizing antibody against RSV infection, which is targeting the bivalent, targeting the prefusion F protein area of the virus. So this is again a clinical trial, double-blinded randomized trial, included patients more than 60-year-old. It was RSV versus placebo, and the primary endpoint was the vaccine efficacy against RSV-associated lower respiratory tract illness. This is the main result. Look at the Kaplan-Meier curve on the right side. The blue color is the placebo. The orange color is the RSV vaccine. And this is the number of cases with confirmed RSV-associated lower respiratory tract infections. And clearly, you can see that the vaccine was quite effective. The vaccine efficacy was 96% for those patients who received the RSV. I think for me, the main problem with this trial was exclusion of the immunocompromised patient. If it's happened and you read the baseline characteristic of the patient population, you can clearly see that all patients included maybe, or maybe half of them just have one comorbid illness. Nevertheless, if you look at the approval of this vaccine in many countries around the world, including here in Saudi Arabia, you can see that the vaccine is indicated for patients more than 60, in addition to comorbid illness, such as chronic lung disease and chronic cardiac disease, etc. So maybe this is one of for the future research to test the immunogenicity and the outcome of this vaccine in immunocompromised individuals. The next trial, again, in 2023, it's the using pitavastatin or statin to prevent cardiovascular disease and HIV infection. This is, again, was a landmark study, phase 3 trial, including more than 7,000 patients. All patients had an HIV infection. All patients, including this trial, were receiving antiretroviral therapy. And the population included here is a unique population. It's low to moderate risk of cardiovascular disease. So randomization was receiving pitavastatin versus placebo, and the outcome was a composite outcome of occurrence of major adverse cardiovascular event. Just a quick note about the baseline characteristics. The median age was 50. The median CD4 count was around 600. And the trial was stopped early, around median of 5 years for efficacy. The main side effect was muscle-related side effects in the pitavastatin group. However, this led to minor discontinuation, around 1% of the pitavastatin group. Look at the forest plot here on the top. You can see this side or the right side represent the pitavastatin group, and clearly, in terms of the major cardiovascular event, this group had much higher success. The hazard ratio was 0.65%, so around 35% reduction of all-cause mortality for patients receiving statin. Again, with the Kaplan-Meier curve, blue color is the representing placebo, orange is pitavastatin. You can see clearly here that the first major cardiovascular event or death, pitavastatin, was associated with protective effect. Next is another new product is the cefepime taniborbactam in complicated urinary tract infection. This was published in New England Journal of Medicine, but this was published this year. Quick note about this product: the taniborbactam is a beta-lactamase inhibitor. Potent activity, has a direct effect against class A, B, C, and D, so including beta-lactamase. And this is, I think, the point where I found this product is quite interesting. It's a product that could make it to our market very soon. So this is one of the registration trial. I don't think it's approved yet by FDA. It's still undergoing the approval process. But this is the first trial. Other ongoing trial for pneumonia is still ongoing. So for the complicated urinary tract infection and pyelonephritis, these are the findings. They compared the cefepime taniborbactam versus meropenem for 7 days. 14 days were extended in case of bacteremia. The primary outcome, composite microbiological and clinical success. So this is a UTI. So as expected, the main pathogen was E. coli, around 70%. Other bacteria, Klebsiella, Proteus, Enterobacter, and Pseudomonas represent around 4%. The main outcome, which was in the intent to treat population, and the microbiologic composite success rate of cure fell within the non-inferiority margin. However, it's quite clear that the composite outcome numerically was much higher in the group who received the cefepime taniborbactam. This is, again, I wanted to highlight that in terms of the microbiology or success in the term biology, almost in most of these pathogens, cefepime taniborbactam outperformed the meropenem, much higher success rate compared to the meropenem. So in conclusion, this product was superior to meropenem in treatment of complicated urinary tract infection and pyelonephritis, and the safety profile was similar. I think the first question you would ask after seeing this result is, how is this antibiotic going to perform for patients with multi-drug resistant, in particular patient with NDM, CRE, and Pseudomonas. Next study, this is just a little bit of change. So this is a retrospective study. It's published in Chest in 2024, anaerobic antibiotic coverage in aspiration pneumonia. As you know, aspiration pneumonia represents a large number of category, around 15% of all cases of community-acquired pneumonia. And although the guideline stay neutral in terms of the recommendation to give clindamycin or metronidazole for these patients, very little evidence exists on the comparative effectiveness of the empiric antibiotics when it comes to patients with aspiration pneumonia. So this was a retrospective, as I mentioned, multi-center, included 18 hospitals in Canada, and they divide the patient in two groups: the limited anaerobic coverage group, where these patients just receive ceftriaxone, cefotaxime, or levofloxacin, and extended coverage anaerobic group, where these patients receive similar antibiotic, however, with the addition of clindamycin and flagyl. The primary outcome was all-cause mortality. So here are the main results. If you look at the Kaplan-Meier on the left side, you can see the two groups were similar to each other in terms of the in-hospital mortality, not much difference. And if you look at the primary outcome here on the right side, you can see also 30% risk of mortality in the limited group versus 32% in the extended group. The adjusted risk different after the propensity score matching. There was no major difference. And in terms of the secondary outcome, numerically, there was a higher number of patients who had C. diff in the hospital within 28 days compared to those patients in the limited group. So in conclusion, from this study, I think the extended anaerobic coverage likely is unnecessary in aspiration pneumonia, and this was associated with a greater risk of C. difficile infection. Despite this, I think, at least from my practice and my observation, it's a knee-jerk reflex that these patients usually receive Flagyl or clindamycin for patients with documented aspiration pneumonia. Next study is the RESTORE study, which is the rezafungin, again, a novel next generation antifungal echinocandins compared to the former echinocandin or previous echinocandin, the caspofungin. This is a multi-center double-blind randomized phase 3 trial. Multiple centers included adults more than 18. They included patients with candidemia or invasive candidiasis. And they compared this product with the IV caspofungin. This product is interesting and it's quite attractive. It's a once weekly echinocandin. So definitely in a busy tertiary hospital, this antifungal could be quite attractive in terms of saving bed, in addition to the safety from catheter-related complications. The primary outcome was global cure at day 14. And here are the main outcome. If you look at the all-cause mortality, 24% in the rezafungin group versus 21%. It fell within the non-inferiority margin. So it was non-inferior to the caspofungin. And also looking at the global cure, they were quite similar. Again, this was also in the right side here. If you look at the Kaplan-Meier curve, those two groups were similar to each other. So in conclusion, this product was non-inferior to caspofungin for management of candidemia and invasive candidiasis, waiting for more result in cost effectiveness of this echinocandin when it's compared to other type of echinocandins. Also waiting for other type of patient population, such as, for example, prophylaxis for high-risk population. The next study I'm going to discuss is, or this is the last trial, is the Sabato trial, the efficacy and safety of oral switch. Probably you heard about this study published in Lancet Infectious Disease earlier this year. Oral switch of patient with a Staphylococcus aureus bloodstream infection. This was an open label non-inferiority trial, included multi-center studies. And I think this is an important point that they included patient with a low risk Staph aureus bloodstream infection. They randomized patient to 7 days of IV therapy and then switch to oral antimicrobial therapy versus continuation of a standard IV therapy. And again, look at exclusion criteria. It's very important to look at this patient population. They excluded any patient with any sign of symptoms of complicated Staph aureus bloodstream infection. They excluded any patient with non-removable focus and patient with a severe comorbidity. The primary outcome was 90-day composite outcome, relapsing Staph aureus bloodstream infection, deep-seated infection, or mortality. This is the main result. This is for the intent to treat population. The primary endpoint was Staph aureus complicated within 90 days, and the group were similar. The group who had an oral switch or continued IV, and again, it fell within the non-inferiority margin. So this intervention was non-inferior to the other group. And again, with the Kaplan-Meier curve, you see that the two groups were similar. However, I think it's very important that to look at the patient population when you try to make a conclusion about this study. Look at this table. If you look at the focus of infection or the patients included in this population, most of them were actually patients with a catheter-related infection and skin soft tissue infection. These represent around 75% of the patient population. Skin and soft tissue infection and catheter-related infection. Also, very interesting points from this study was if you look at the echo, whether transthoracic echo or transesophageal echo was done only in 64% of the group who received in the oral switch group and 57%. And it's quite interesting that these patients, after 7 days of IV therapy, were switched to oral without having at least a transthoracic echo. Also, an important finding from the patients included in this study, the patient with an MRSA represented only around 5 to 10% of the patient population. So these, I think, important consideration when you try to switch or thinking about switching to oral for Staph aureus bacteremia. I think looking at this study, the main limitation for me was the open label design, since many of the outcome were assessed by the investigator. And in conclusion, I think it supports the early switch to oral antimicrobial therapy for a patient with a low risk. However, what is the definition of low risk Staph aureus bacteremia? It's still not clear. So you need to provide rigorous clinical assessment and close monitoring for complication before considering this strategy. I think I'll stop here and I'll be happy to take questions. Thank you.